to form the what? The hepatorenal pouch. Right, so it's demarcating the bare area from the hepatorenal pouch.
Okay, so you can see on the right side, my fingers are indicating a triangular shaped area, don't they? This is the right anterior superior, and down here, the right posterior inferior, and then the right triangular, yeah? So you see, you know, the apex, and you know the two sides of the triangle. That's the bare area devoid of peritoneum. Yeah? And this bare area will have its capsule, its specific capsule, and it's intimately related to the diaphragm. And the base of this thing now, of this triangle, is formed by that structure which has been opened up. You see that? Yeah? Now you see that what is going on? So the base is formed by what? The IVC. Okay, so that's nice and easy for you to understand. Now, this is the costal surface, and you can see the impressions of the ribs and cartilage on top. This is the superior surface, and this is the anterior surface. And the anterior surface, nothing about important except for the falciform ligament. Yeah? But what is important for you, the students, know, is the surface, the visceral surface. Huh? The superior surface, the key thing are the coronal ligaments and the Biliary area. What you need to understand is what's going on the visceral surface. Huh? You see this structure, you can see it? This is the gallbladder. Yeah. And sometimes you might have the surface marking for the fundus, which is this portion, the blind Indian sac of the gallbladder. Yeah? Meaning a positive mark is sign when it's inflamed with gallstones. Eh? And remember, this is the right line of the right line, costal cartilage, the spigelian line or the semilunar lateral wall of the rectus sheath where they intersect. Okay? So that is regards to that. Now you can see this nice depression on the right side. Eh? And Mr. Gardner just highlighted it to you a while ago. This is related to the right kidney. You can answer that. So you can't miss that. Eh? And this area of the bare area now, right about there, and the superior medial aspect in relation to the right kidney, right about this vicinity is related to the right adrenal gland. Eh? Now, between where the gallbladder is and where the lower ligamentum teres is entering there, there's a roughly quadrilateral shaped area of the liver. And that's the quality of the liver, yeah? Yes? And adjacent to where the inferior vena cava is, yes? I showed you that. There's this little, they should probably call it lingual, like a
linguiform process of the caudate lobe.
Anyway, all of this is the caudate lobe.
And then the process
linguiform. Looking like a minor tongue, a small tongue. That's the caudate lobe, okay? So you know two lobes, quadrate and caudate lobe, okay? Yes? So make sure you understand that so far. Good.
So we have 4 lobes in all, right, left, quadrate, caudate. Ready?
Yeah. Now when you look at the caudate lobe in its entirety, you see a portion that's coming to the right side of the liver. Yeah? You see that? A little finger-like extension. Anyway, I should use the word finger. But there's an extension to the right lobe of the liver, right? And that is called the caudate process. Mr. Gardner will tell you that there are three processes associated with the caudate lobe, right? The first is the caudate process going to the right. Huh? This one not really showing it, but going to the left sometimes. Yes, going to the left sometimes. Going to the left sometimes. I don't think any of these show it.
Yes, a popular kind of a popular process.
Okay.
That's it.
On this
Zoom
specimen,
down on it, zoom down on it.
on the specimen, right about there.
Papillary process.
This is left side for the stomach, that depression, eh? And you see that there's an extension. It's pretty small in this instance, eh?
Can be quite large,
But
like a
sometimes
finger.
Sometimes it can be bigger, long.
Big.
Yeah. Going to the left.
So what happens? It gives like a fishtail appearance to the caudate lobe at the end, like a fishtail.
So you all see that, eh? And what you call this again, Joel?
Papillary process.
The papillary process. Say how in exam, we might say which of these is the papillary process. So you may remember, Joel.
Papillary goes to the left. And body goes to
You know, in the heat of an exam, when you're under pressure, everything goes out of there.
Right.
Don't it? After you have experience that.
pointing one there.
Huh?
Pointing one. The thing that I point.
But this is pointing too.
But it's less pointy, you know? So,
No, it can be bigger.
one
You see, that's why I must come to lectures now. Tell them from the L. The L is for left, and which one of these spleen processes have polypi L's?
Oh yeah, I remember you saying that.
I said that was, I tell you stupid things, you know, because you remember the foolishness. When we talk to each
Correct.
other, remember the foolishness is more than the factual.
The more anecdotal thing.
That's what we remember when we talk to each other. That's why we have so much fun when we speak to each other, don't it? Like when we're in love, we talk like a lot of nonsense, you know? You understand me? And you remember those. And then they are more meaningful than the factual events. The third thing now, let's see. The third process in relation to the gallbladder is it? You guys remind me again, I told you. Okay, the one, that one. That has been moved. To the vena cava, yeah?
Oh.
To the vena cava. Yes?
This one is hidden.
Yeah, this one. Sometimes you might have, that's going to the right now, you know? You might have an extension or pieces, not pieces, small amount of the falling going towards the right and covering over the inferior vena cava. Understand me? Well, that could be the linguiform process or the vena cava process, yeah?
It may form a complete bridge.
Right? So depending on the thickness of the tissue, it might form a complete bridge, eh? And you use, some people, you use the word pons, you hear some, right? Not
just
the
once
pons.
for the embryonic fission. And then also the bridging there is the hepatocaval ligament.
Yeah, it's same thing, the hepatocaval ligament, okay. So you need to understand it. So that's clear?
yeah.
Good. Okay, so we showed you the depression for the right kidney, the biliary here adjacent right atrium. This is for the stomach, eh? This depression there. Yes, for the stomach and full.
That one has a very large tuberomentale, Patrick.
Here, so.
So what is in relation to the tuberomentale? It kind of gets some freedom to expand. So
The doctor
something.
mentioned it, yes.
Yeah.
2
So
days ago,
what is
yeah.
right there? What would be What would be kind of there? See, so look where you can. So it shows if you can reconstruct things in your mind. You see, look at the depression for the stomach. You see the depression for the stomach. trace it upward and you'll get the esophageal impression, right, Patrick?
Yeah,
Then
right
you-
here is the esophageal.
Right, then you get
You can see
that big,
there.
that area that bulges out called the tuber mentale. In relation to what? What would be there?
So what's above the lesser curvature of the stomach?
For the lesser.
Lesser curvature of the stomach, man. And is it way before jumping into the body?
Yeah. You have to reconstruct things in your mind, you know.
The notches there, yes, but this portion was above. That portion of the pan, where I'm living, you know, the pancreas, above the lesser curvature. Some people use the word, what is it, a mental tuberosity
Tuber mentale.
or tuber mental. Doctor mentioned that to you? Huh? And that's why it's good to hear what different people
So,
talk to them. So I noticed Brandon isn't here this morning. He's here? Good. From I attacked him because he was in love with a little lady here. These Indian guys like which are serious guys. Yeah, I mean the less momentum there are. What is another name for the less momentum again? Apart from hypothyroidism, but I guess. Yeah, to burst and that's not for lessons. So this is what Mr. Gardner is, and then you see we give you 2 points free there and there.
the lesser momentum. From the lesser momentum will go down to the lesser curvature of the stomach. So just watch the depression for the stomach so above the lesser momentum.
What you must be familiar now with is a number of these structures that we might show you in the exam. A number of structures. And one of the structures, we can put the thing into it like that. Yeah? No way area. Always in the specimen, get the orientation right there. And you see we now have a tubular structure. Eh? What's your name again? You're a D2?
Yes.
Which one is it again?
Danny.
Danny. Too much D and confusing. So, in the examination, they have to put a little probe in this thing. And ask Danny, what the hell is this thing?
Is it a partial vein?
You guys agree with her? We tend to agree with her, you know? Huh? Yeah. And if I should hold this, and you guys can see lumen there. What lumen is that? Yo.
That's you then. Once a year.
What lumen is this one? You don't say lumen?
Yes.
Sarge.
Joel being so smart says that. Yeah. Joel's so bright says this is an arch.
Wait, is it the CBD? CBD, is it the CBD?
It looks like a doctoral structure to me. Because you can see the gallbladder is coming down. Yeah. So in example, they have voluntary information. Yeah? So this is the gallbladder with this is coming down. It's going and join with the hepatic duct, which is the structure. So this should be the common band, okay? So don't forget that. The only other structure up here, the third structure should be the artery. It should be somewhere about here. Anyway, wherever it is. But make sure that for the exam, you are very astute about that, all right? Now, we talk about where our relationships. So yes, the gallbladder is there, and what structure tend to come up near to this junction? This is the duct, yes, and the hepatic duct. What structure tend to come up near it? It's coming home.
The right hepatic.
It can be the right hepatic. The right hepatic are coming from the right lobe of the belly. Put them in up here, man. We're sure you know that. So this can be related here. We talked about the superior duodenal flexure coming up here, right? It's coming up this facility here. And to the lower part now the corresponding column flexure. Okay? Down here. And pieces of the transverse scrotum. Anyway, what I didn't show in the lecture, well, let's go to the lecture. We mentioned that there are a number of fissures on the visceral surface. This is why you need to know this surface so good. Good. Where the ligamentum teres is coming. Here it is, it's running in a fissure, no? Yeah? You can see that. You see the fissure? Yeah, so what we call this fissure? The umbilical fissure, that's up. And as we continue upwards, it continues into another fissure inside there. Yeah, you see that? You get the impression that there's another fissure there. And what fissure is continued? The umbilical fissure, what's superior? Sure.
What is going on about?
They're going to laughing with you, not at you.
We're
Laughing with you.
We're laughing at him.
No, with them. Laughing at him versus laughing with him is another totally different. No, correct. Because he know that he made a mistake, and you know he made a mistake. You know?
It's okay.
So what is it again? Right. The fissure from the ligamentum venosus. They are almost in continuity, as you can see in this specimen. Notice? And the gallbladder with the inferior vena cava, this piece of guy here, they are almost in the straight line. Notice? Notice? Yeah. With little imagination.
So, students, if you just look at that, your grade Dr. Lodenquai has the probe going through, and you see the very nicest how these things are placed here. Yeah, just right like that. You see the structure crossing across there. Look what that makes, like a letter what? H. You see a letter H?
Yes, I
So,
see it.
so there is where the forceps was right here. There.
Oh.
Yeah? You see a letter H?
Capital H by the way.
Capital H. Right. So this one here is called the left sagittal groove. Right? And that left, don't mind actually, that left sagittal groove below is the fissure for what? The ligamentum teres, or the embryonic fissure. And this one is for the right. And then the one down on the right side, this is the right sagittal groove, right? Can we call it same? Okay, and this is going right through the groove for the IVC and the bed of the gallbladder. Then there's a transverse fissure, and that transverse fissure is going right across what? Good, that's all clear.
Yeah.
But they showed it nice, Patrick. Just when you're
Yeah.
there, you can see the letter H beautifully there. Okay. Thanks.
Right? And the transverse fissure which Joel wanted to tell us about was formed mainly by the right and left branches of the portal vein. So you understand that, eh?
And that letter H is going to divide it up into what we call the 4 lobes. Right, left, caudate, quadrate.
Now, when you look here on the right side from the portal, look all of your books at it. I didn't show this in the lecture series to you. On the portal to the right, you see this groove here, don't you?
And this one is very big.
Yeah, this one is big.
Ask Brittany what that groove is. See Brittany right beside me, Patrick, right here. Yes.
What is this? You have to know what it is.
Revere's.
This is known as Rovere's. Rovere.
Henry Revere.
So, yeah. And the key thing is that it is said that the right hepatic duct is found in the depths of this fissure. Rovere's sulcus.
You're right, Patrick.
Okay. Mr. Gardner has wrote articles about this fissure.
With Dr. Lenny.
Yes, the man that wrote several articles about the many variations.
We have about 2
pertaining.
papers on it with that third coming.
And similarly for the umbilical one, notice there's a little bit of a tissue over the ligamentum territory, yeah? Fibrous span. Similarly, Mr. Gardner wrote several articles, papers about this. Different, many variations they have.
I wonder if any of them have a concept of this. You see the concept of it? Yes. Yeah, right.
Okay, so you understand the visceral surface without any sweat. Yeah? Look at it again. Come back to that and look at it again. Yeah? So, the liver, it has a capsule. Yes. What is the name of the capsule? Right.
So just tell us. So when you look at that fissure, you look at the screen there, Patrick. When you look at that in the screen there, look at it. So when you look at the fissure here for the embryonic fissure, in Caucasians, it's nearly all just a clear highway, like you're going from here to Ocherius. In people of Afro descent, and anyway, the Jamaican population, only about 23% are clear. Okay, it's only 23% are clear. So in the Jamaicans, it's a busy road, very, very busy. A whole heap of things are happening in that fissure. And in some cases, you don't see it at all. There's no fissure. It's all bridged by the pons hepatis. And there's a tunnel going on there called Rex's tunnel, or the recesses of Rex. And then sometimes it's partially bridged, and the bridge may be occurring anywhere along it, okay? And then now, in this case here, which is very rare, you may see a fibrous band. So when they want to do what they call a Rex shunt, which Dr. Lodenquai will talk about later, it becomes very complicated. So remember, in Caucasians, just a clear, empty room, space. But in people of Afro descent, it's a busy road, and there are all kind of things happening on it, and sometimes the road is not there. Sorry, okay?
Yeah. Surgical in the reverse sulcus is important, especially at laparoscopic cholecystectomy. You want to stay. Yeah, because when we're doing the laparoscopic cholecystectomy, the liver was like that in the patient, yeah? And when you insufflate the air and you elevate the liver, like pulling up on the gallbladder like that, you see the sulcus is there below, don't it? See how to stay above. Okay? So this is capsule. When these major structures are going into and out of the liver, the capsule follows that. And when that capsule follows into the liver, ultimately it will follow the triads, don't it? You know what we call the triads? Branches of the duct, portal, and the hepatic artery. They are called the triad. And these triads are tend to be surrounded by derivatives of the distance capsule, yeah, the fibrous capsule. That accompanies them. So, you know, we always drive in and crash like thunder. right? And we're always bashing up our livers as a result of that. Blood trauma. Keith Crystal, no? So in blood trauma, bleeding more commonly comes from which of the three vascular structures that goes to the liver? That's the liver. And why? You get a blunt injury to the liver, and the force is going to rupture the liver, yeah? And it's going to bleed when it ruptures. And there are three vascular structures to the liver. That's not in the liver. What are the three? Sorry?
That is hidden in
Yes, that is what I'm calling it. So we have the hepatic veins, yes?
veins.
And the other vascular
Right.
branches of the hepatic artery. No man, ignore the vein, you're talking about the liver itself. You know it, and we show you. The portal vein. Send blood trauma to the liver now. Which of these three structures is bleeding most likely to come from a process? And then why? It's a portal vein. What you say, Anthony? She guessing it. So you have the multiple choice now to guess.
Yeah, I would say portal as well.
Ask a man named Sam.
Sam.
Sam. It would be the portal vein, the
Artery.
hepatic artery,
Or
or
the
the
hepatic
hepatic veins. In trauma, which one would you expect to bleed more and why?
So these seniors come to the conclusion that it must be the. Well, she said it, you know.
Why you say the hepatic vein?
It's the hepatic vein radical.
It is the hepatic vein.
Because the one vitamin it's more,
One is protected.
it doesn't, yeah, it doesn't have as much protection as.
What is protecting them?
What? What is protecting them? The capsule.
Yes.
Yeah, and what's that capsule referred to as? Give it a name. Whose sheath?
Whose sheath?
Yeah, that whose sheath enters into the liver.
Oh, you mean, so the
Whose
glisten-
sheath? I just want to know the name, man. Glistens.
That's a,
Okay, so you understand?
And branches up. So
The
it
thread,
it's going to
the
branch
thread, the
up.
hepatic artery branches and the portal vein branches.
also when the glisten
With the
capsule
basal.
goes in, it's now called the
So they are
glisten.
surrounded by this capsule.
Oh.
Yeah? So when they
Glisten is
have some bleeding from it, you can see where the fibrous capsule is going to compress down and squeeze down on the artery. Yeah? Where the vein in the middle, which is on histology, is unsupported, nothing supporting there. So it just will bleed and bleed. So it's important for you to understand that. Yeah? So we told you that the glistens capsule, as it goes into the liver, that we recognize a number of plates. Eh?
Yeah.
My friend at the back there, the classes of Voodoo is in a black shirt.
black shirt.
Is a black shirt or blouse. Cass is the wood from
What are you talking about?
the person in the black there. Yes, man, you.
Oh, you mean the black hat?
Not the hat. Somebody during a hat.
Oh, boy. Sir, I don't know who you're talking.
That's the guy that are stand up. Is Dimitri that?
The guy in the glasses? The guy in the glasses, sir?
He has glasses.
The one who's waving?
No.
Is that girl? Is that girl? She in
No,
green.
that. Oh,
Is that girl? Is you in the green with it?
yeah, good.
You know, wait. I think I'm going to just zoom up on this machine. I'll try and speak to this machine.
Yeah.
Just look at this zooming hard on it.
Get some more.
We guys are colorblind, you know that.
Just explain.
Most guys are. Okay. I was just asking because if they had come to the lecture, they would have heard I mention these plates, eh? And one goes by where the thread is going into the liver, the hilum, yeah? And it's called the hilum plate, right? Another is whereby the umbilical fissure is where the ligamentum terrae is going through. Yes, and that is called the umbilical plate. Eh? One is by the vicinity of the gallbladder.
So,
Where the gallbladder is, we divide that peritoneum, and then we get into the plate. You know? That's the cystic plate. How many we got?
3.
That inside the peritoneum here. So what's the role in the gallbladder to the little fibrous tissue portions of the glucose capsule? All right? So that is the cystic plate. And what is the last plate that we know about? You remember we did the heart just last semester? Yes, can you remember so far back? And we look at the aortic and pulmonary valves. You can remember so far back? Roughly in the center of, remember you have the aortic and the pulmonary cusp valves, right? Cusp, right in the middle of each. Yeah, you have a little thickening, no? A nodule. When they come to the snapshot. And what we call that nodule again, you can remember so far back? Yes, somebody just said it. You said it?
Nodule?
Yeah, he did nodule.
Of who?
I think Brandon knows it. I think Brandon knows it.
I think it's the Arantines. I don't know.
Right, you're almost there. He said an A word, that's all?
Yeah, is the one with the ligamentum venosus down.
Okay. The Aranchus nodule. Remember, you learned all that last semester. For them to remember so far back.
We must remember the heart.
Okay, so the fourth plate is the plate of Aranchus or Aranchian plate. Eh? I will make use of these facts, you know? Because before you actually came in,
And they also form gates into the liver country.
yeah, they get our influence. I was just dissecting briefly and along the hilar plate. Had incised like I did with the scissors. And as you can see, there's nothing important in this hilar plate. Eh? With me? I can gently separate off. Remind the liver it is more flexible. This one, everything becomes hard.
So that means
Yes, but I'm saying it's hard.
In vivo.
Yeah. So you see what I'm doing? You see what I've done? I've incised the peritoneum and dissecting between this segment of the liver, which is called segment 4, and the hilar plate and the hilar below. And you see I'm separating it off, eh? Like that, don't you? And I'm destroying anything, eh? You agree with me? So that's what I've done. And what I've done, the senior residents can tell you what is this what I'm doing, what is this procedure resulting.
Senior resident, what is this?
What procedure is that?
Senior
Not the name of the procedure, but what is they call what I'm doing. I have separated the hilar plate which was stuck. You can see the fusion was there. I've dissected it off like that.
Blood dissection.
Yeah, but you guys have to know something pretty just have a blood dissection.
Is it?
Some of the students might know. Those who come to the lecture. And those
They
who are
come to
not-
the lecture, they're all there, Pat.
No, they didn't come.
No, they're all there in
The
the
heat
lecture.
that inside that place killed me still killing me.
I was in their dining.
You see? You see what you have done? And now we have the, where's the note? This is the note. You see, now we can dissect it up more easily. Like that, right? You see what I'm doing? You see what I'm doing? So the residents don't know what I'm doing.
What are you doing?
Exactly. Tell them from in Charles.
It's command senior resident. What about Sam?
I don't know.
Senior
He's
resident.
trying to what? He's trying to isolate the dog?
No. It's cutting into the high plate.
And you see, I've separated the head of plate from the segment where the liver there. Yeah? Bluntly.
So the things will fall down.
Right.
Okay.
So all of
So
this
is it
is-
going into the cystic plate as well?
So all, no man.
No.
All of this is called lowering
Lower?
The higher plate.
of the highland plate. Eh? You see that? It was for stuff like that up here. And I can
Right now, the lowering of the higher plate.
Why would you lower the
All kind of things, man. You may
I'm going to show you.
biliary atresia and
Seeing is believing. This is the duck, eh?
Mm-hmm.
What about the left hepatic duct now? What do you have to tell me about the left hepatic duct in relation to the high duct? This is the left side, so? So you know it's coming there. The left hepatic duct has a long extrahepatic force. And by lowering the plate now, you can see where I can dissect further. Yeah? And find the left hepatic duct. Yes. And having found it, then I can do my anastomosis, bring up gut and join it up. Small bone and join it up at the highland here on to the left hepatic duct. You see that? So that's the significance of knowing about this lowering of the highland plate.
Oh, so like when we're going to do the bypass procedure, then we need to do a
Like following
cholecystectomy.
Yeah, you're gonna
Okay.
small bone and join it up.
Alright.
So you see by lowering it, it becomes more the duct, more access.
Okay.
Okay, so we have one nice big fat liver.
The left, huh?
Yes.
I don't know what you said.
And Melissa, we said that the liver now is divided into two right and left lobes, right?
Yes.
Oh, you weren't there.
January. Oh, wait.
She was at the lecture.
I can still read.
Okay, so where is this line now that separates the right and left lobes of the liver?
Oh, the Can's line.
Right, Cantler's line, or GER, G-E-R, or Rex's line.
Main
And
portal
it
is here.
passes from
Line
where?
of bricks.
I believe, is it a notch on the liver? On the...
Oh, this is the whole connection. Don't you think you look at the interior wall of the whole connection?
I'm just setting up myself.
It's just passing through the different fishes.
So we have to be exact. You want, what's your name again?
The cystic.
Dini. Dr. Dini. I can't remember her name. Where is Cantler's line now, or plane?
Well, it's basically running on the posterior surface of the liver.
Do the
So
cystic
it's
notch.
running basically from the ligamentum venosus fissure to the teres, and it comes around.
You see why we guys have it hard with the girls, you know? They know what they want to tell us, you know? So they take a hard time in telling us what we want to hear, you know?
I have to relate
I
it to
don't
my
understand.
What they want to hear.
Isn't
It's
it
a
just
line
from
drawn
Oh,
through
really, really, they want to do
the
it.
iris and
the
the
middle
isn't it?
of the gallbladder bed, eh?
That was a very
To the left of the inferior vena cava. As simple as that. You get that? As simple as that. So you're going to make a cut through the middle of the gallbladder,
Is it the
Yeah.
right or the left of the RBC?
right? And then we continue the line to the left of the inferior vena cava, which is up here, right? Yes?
Yes.
Now, so I'm going to cut that for you. So in real life, when we want to cut tissues in the body, we ask for a scalpel blade. Now, would you cut the real liver in real life with a scalpel blade? Left. Left of the IVC. Yeah.
No,
No.
the left of the
So what's the call? Right. Would ask for the scalpel blade when we're cutting the liver? Would we use a ask for the scalpel blade when we're cutting tissues? We ask for the scalpel knife. So we cut the liver with the scalpel blade. Yes or no? And you know the answer. What is that? The answer is no. And I explain to you why. When we cut the liver, it bleeds profusely. Yes. So you use a sharp scalpel blade. And that's related to your first term when they taught the hematology. I talked to you about it. The madman will chop off your hand. I'm going to yank it off. You understand me? If you sharp, you yank it off, boom. It bleeds and bleeds because, as compared to when you yank and twist off a pop off your hand.
No, that's wrong. Goes to the left of
Because when you're sharp inside the thing, not much tissue factors are released.
Just show you how sometimes somebody texts say the wrong thing. Because
They do.
in the text. So remember that, it goes to the left of the IVC. So that's very important. Right?
Okay, so we don't use a scalpel blade. We use blunt instruments. So we can use like the back of the, well, you never saw what a scalpel holder look like. Blunt. So I'm going to use the blunt to deliver it. There's a gauntlet about here. These livers are so hard that you can't. It's a few diseases, yeah?
Why
There's
don't you just
one
something?
that already separated.
He wants to show how it's done.
All right.
Yes, nice there.
So this is what I want to do. Or sometimes having made an opening into it, they are more sophisticated instruments at the university, unlike university, government, and other hospitals. A special scalpel, they call it a harmonic scalpel. And based on the principle of ultrasound, it cuts and seals at the same time. Eh? Anyway, when we're doing this now, is it? See? Here. It's just when I push the thing down more and apply ground force. Sometimes they can call finger fracture too. Use the finger. You see, it hits on something here. So there's a portal thread that is holding it. Yeah. You follow me? So we have to recognize this is there. And then we continue along that line to the left of the inferior vena cava and the vena cava right here.
I think
And we continue opening, but these livers are so hard that I will just check.
You have to go down more. Go into it once. No, please more.
This is my harmonic scalpel.
Exactly.
I have a question.
Yes.
When they're surgically removing a portion of the liver to
Give a chance, doctor. He's operating on the patient now. We don't want the patient to die. Working on the man's liver. We don't want him to die, all right? And see what Dr. Lodenquai is operating.
It's good.
That's a strong hand. So you can see now we have some veins here coming up. Yeah?
These surgeons are watching before you operate.
Yeah.
They're replicating.
So these are now going to be
So bring it on a bit, it's not showing the camera.
yeah, to the middle of the device.
Yes, sir, is that right? Can you, sir?
So you can see the middle hepatic vein running like that. It's going towards the vena cava. If I should clear this out somewhere. That's not it.
You're doing an excellent job there.
No, that's what I'm saying, Anthony. I'd rather not. I'd rather not.
You see the middle hepatic vein here now? Down there. You see the middle hepatic vein there? You see it? No?
Your fingers.
If you tell me where to look for it,
Or you're not seeing it?
I can just on
Okay,
this
see
one.
there.
Okay, see there now?
Okay, fine. There was no way.
Running to
I'm on the square.
It's a small little leaf, and this is a tributary to the left. Okay, so you see it? So you see, you don't see it?
It's the angle, like it's the angle.
Stop. Go down.
You don't see it now?
Right there.
Beautiful.
Nice.
That's the middle.
Middle hepatic vein.
So it runs right in Cantus Spleen, eh?
Mhm.
And I made my incision in Cantus Spleen. And I find it, eh?
Mhm.
So that's nice and easy. No, the other plane. So that's the right and left lobes of the liver. You can see that.
Yeah.
Cantus Spleen divide the liver into right and left, right?
Yeah.
Now, when we go where the falciform ligament is, and this is another one of Mr. Gardner's famous litters, you know.
Yes.
You notice this falciform ligament doesn't enter on the visceral surface of the liver, don't it?
Yeah.
So that's another anomaly.
Anomaly. It's entering more on the
Anterior surface.
the anterior surface of the liver.
Right.
So I'm going to make an incision into that plane now. eh? Well, I hope it will follow the route because this is not a normal. It's not
That's not anomaly.
Oh.
So what was wrong with the person?
Huh?
Just the Jamaican, the liver in our population does not conform in a number of respects.
Excuse me now.
And if you go to India, you see something different. I don't know what in China.
Because they need to drink more rum, bro. So them
Each
live off, you know?
population has their own
Yeah, bro, they got that, bro.
variation.
Okay, so you saw Cantus Spleen or GER or Rex is a spleen, right?
Yeah.
And that in the nomenclature of the hepatic guides, that's called the median or middle caesura, SCISSURA, middle or median caesura. Middle, median, divide the liver into right and left, and this off. This one now, and this is nice chalky, because I didn't have to really cut through in this one here.
In fact, I find the surgery is going very well today.
You can see in this one here now. Now when they see the thing being done, they appreciate it more. See the ligamentum teres, which is normally a vena, and they come up with teres. And you can see it's going there. It's going there. And if you decide further inside here, it's going to the left. It's going to the left branch of the portal. Okay.
Is that Ali?
And you can see
Same, bro, same.
you can see going toward the left branch of the portal. Yeah? Yeah? And this portion is called the pars umbilicalis. This is spatial here.
That's you, Dominic.
And the transverse portion of the porta vein is called the pars transversalis. So this now fissure, if I should continue, along which was this guy was open here. It's called, this is median caesura. This is the left caesura. Huh? Yes, sir? Median separates the vein to right and left lobe. Right lobe, there, left lobe.
That's not your left medial.
The left caesura now, which consists of the umbilical fissure with the ligamentum teres, yes? And the fissure for the ligamentum venoso. Yes, you see that? Yeah, you see that? This is called the left caesura. Yeah? And it will contain the left hepatic vein. So you see the left hepatic vein here. It's really in this left. The left lobe is now divided into a left lateral section or sector. And a medial.
2, 3, 4.
Medial.
Medium.
Medial.
Medial.
Medial section or sector. Okay? So you can see the left hepatic vein there, right? It's really in there. Yeah? See, understand the left caesura separates the left lobe of the liver into a medial sector, left medial sector, and then left lateral sector. That's clear?
Yeah.
So you see the middle, and hepatic vein, and you see the left hepatic vein. On the right side, the plane is not also obvious, but usually the line of the starting through. From the vena cava, you make a line for about 5 centimeters from the inferior end of the liver like that. Yeah? So somebody had marked it out like this early. And we cut through, and we cut through, and ultimately we cut through. And that's why it's good working in a Chinaman shop. You know?
I beg your pardon.
Because we had to cut the saltfish when the people wanted to form a saltfish or a saltfish or mackerel, etc. You understand? So it's good training.
Early training.
Early training.
Sure, he didn't get some training like that.
Father didn't have a Chinese.
Let's go back.
Because he's not Chinese.
I'm not Chinese.
And that was the first time I saw Rasta man, you know, because after they smoke the thing, the eyes become dilated and red, you know. And they are hungry, don't they? So the man come in the shop and ordered. My parents were at lunch, you know. Remember the lunch room is right beside the shop. They were at lunch and I was there in alone in the shop. And this Rasta man come in here for the first time this Rasta man.
That was in the early days.
Yes, with the eyes dilated and red. We want a half pound of sugar. We want to go with lemonade, lemon, crackers. So I could sell them the crackers and the lemonade. But he wanted half pound of saltfish to eat with it, you know. And the rule was that I was allowed to use the machines, you know, the chopper in the shop. So I had to call the parents to come and cut the saltfish, you know, right? And I was so glad that I had to go call him. Because when I called him, I was in the back shaking like hell, you know. From seeing this first man for the first time, you know. And you see that guy? What is that structure?
That's a big one, eh?
That's the right hepatic vein. Remember, this liver is small, so that's why the other one is so small.
That's a good one, it's
So this is a nice one.
But to show it again, that's really a very good one.
Okay, so
Take
you're
a
not
picture, pretend.
in the right hepatic.
Very sexy vessel, very well.
That's what.
It look like it got Jimmy Rowe.
Okay, so you see that. Huh? So the right lobe of the liver is that now. And this right caesura divides the right lobe of the liver into the right anterior. All of this is called the right anterior section. Right anterior sector from the left posterior sector. some the right posterior, because that's how it is in the real body. Yeah? So you can see why this anterior, right back is posterior. So we have four sectors, right posterior, right anterior, left medial, left lateral. And with the transverse spleen that Mr. Gardner highlighted to you, zoom across transverse.
Now you set that line, watch it go again and you see the groove. That's sometimes referred to as a portal plane.
Yeah.
So the portal plane is going to go right through the branching of the HPV, the hepatic portal vein. So it's going to divide into superior segments and inferior segments. So the radiologist therefore will know whether where the tumor is based on the branching of the hepatic portal vein. Segments above and segments below.
So you all understand the sectors, right?
They go right through the portal
And the
hepatic.
portal transverse spleen going to divide into all of these sections into superior and inferior.
Segments.
Right, segments. So follow that? So having said that, you know, which is segment 1?
Caudate.
Can you see the caudate from the front of the anterior surface?
Not really.
No, you cannot.
Not really, bro.
So it's the thing there, caudate is segment 1. So if we follow this transverse line, yeah? You see that transverse line? This upper portion is called segment 1. 2, the segment is called, and all of this is called 4. And this now line, this segment 4 is divided into a portion above A and a portion below B, 4A and 4B. Continue. 5, 6, 7, 8. As simple as that.
Period.
Okay.
Yeah.
Well, then it's the segment 1 already.
Just to show them again.
Yeah, the final is a caudate.
Inferior to the LEC.
Yeah, so see the caudate here. And the caudate lobe is number 1. And he's different from the others.
Yeah.
Because he gets dual arterial inflow from both right and left, dual portal inflow from both right and left branches. And its duct will usually drain, the venous return straight into the vena cava by some short, small hepatic veins. And the ducts will drain into both right and left system because it is there. So that is the liver. Now
So the left is.
the hepatic duct, I thought hepatic duct to show them, or rather diagram to show them as section 9. I don't have a diagram to show them, do I? Not a read, not a full.
Yes, the CBD coming out right there.
Left up side.
So this is the common side of the
CBD.
CBD, common side of this is the Gardner. That's the orientation. This should be the Gardner. This is the Gardner.
This is a bit of
I don't know.
Okay, so you said this tubular structure, right? Stick wall, right? So that is the hepatic duct. So the portal vein there. And the artery should be beside it. Now, the common bile duct, the supraduodenal portion, how it gets its blood supply. Common bile duct.
Somebody say super duodenal actually.
Sorry? What about the seniors? How they common bile duct get its blood
I'm
supply?
not gonna sell my oil, go and guess real.
Hold on, you told them yesterday in the
Sorry, what
histology
is it?
lab. So
Sorry,
who was
I
it?
don't
So
know.
look at that, Melissa.
Just start coming
She was there
down.
yesterday.
She was in, no, Melissa, where's Crystal? Crystal is hiding, you know.
Yeah, she's,
I don't know what is happening today. She's in the back row, she's in the back seat of the car and you can't see her.
yeah.
So, Melissa, see how was what was Dr. Lodenquai saying about the blood supply yesterday in the lab up there to the supraduodenal part. Try to remember. And he used a clock. Just like how we remember we have what? 3, 7, we have 3, 7 and 11 for the branches of the superior hemorrhoidal artery. Yes or no? Yeah? So yesterday I was saying that there's a longitudinal anastomosis on the common bile duct and there what hours?
I think Crystal would love to answer this. So I'm going to pass it to Crystal.
Nobody can remember.
3 and 9.
Can't remember at all.
3 and 9.
3 and 9, yeah.
Come in, Dominic, big.
3 and 9.
3 and 9.
From the cystic artery and from the hepatic artery proper, they get branches and they form two longitudinal channels at 3 and 9 o'clock positions.
So therefore you cut out?
3 and 9.
No, you would cut out 3 and 9.
The blood vessels rolling. But we have to explore the common bile duct. 12 o'clock.
To avoid the
That's straight in front of you, in the middle. Yeah? To explore the common bile duct, yeah? I would say the infraduodenal part, the blood supply is differs in that it is supplied by a
What's the question?
the infraduodenal part of the bile duct, common bile duct. How it gets its blood cells? Similar to longitudinal channels? No. How? We said it was a plexus, plexiform arrangement. Yeah. Anyway, Mr. Gardner is getting his pancreas ready. The pancreas, like other organs in the
Hold on, we
body.
don't need pancreas today.
Eh?
Yes.
You're mad.
Yes.
No, it was with the bar
No, man.
Yes. Pancreas and spleen.
So the attempt was by surgeons to divide all of these organs in the body into segments, like the lung, bronchopulmonary
The
segment,
pancreas is so
the liver
Anytime.
into hepatic segments.
11:26.
And similarly, the pancreas, they made attempts to divide the pancreas into segments. Eh? Now, if you pay attention, the pancreas, which Mr. Gardner going to show you. He's going to
Because I told you just liver for today.
Yeah, sure.
They use the neck as the division of the liver. That's the middle. So we describe two segments. Segment one of the liver
Oh, let me get my
consists of the
specimen.
head and neck, the caput cervical.
For what, the pancreas?
Caput
You
head,
can the pancreas and the
caput is head, caput cervical portion, the head and neck.
You know pancreas?
Yeah?
Todd?
And the corporal, yes, body, and caudal, the pancreas, which is state segment 2. So we have two segments of the liver, of the pancreas, yeah? But the important thing now is that this line of division is made where? At the neck. And you can see at the high level the blood vessels are coming in, and the original separation of the segments of the liver was based on this portal inflow. So the inflow of the pancreas at the neck. What's the inflow of the inflow to the pancreas at the head? At the neck, sorry. Huh? The arterial inflow to the pancreas at its neck. I mentioned it yesterday.
So splenic vein.
The arterial inflow. Yes.
The dorsal fin of the
We told you yesterday what's the biggest branch of artery in the pancreas? The dorsal pancreatic artery. And it's coming, someone said you said he said, but you know, remember what we got here. Out of here. The dorsal pancreatic artery comes from the splenic artery. Right at the neck. The dorsal splenic artery comes down behind it, retro, and then it divides into two. Right? And when you just study the arterial supply to the pancreas, it's not hard to remember if you follow the principles of the supply. We keep telling anatomy, at least from me here, that only Dr. Thomas tell you. As it was in the beginning, so it shall be at the end. Word without end. That's not. When you look at the head of the pancreas now in the loop of the duodenum, at the top of the head and the bottom of the head. You with me? You have two branches from both, that's all? And the two of them join. At the top end of the pancreas, pancreatic duodenal region, you get what?
You get an anterior and a posterior branch.
Right, you get anterior and posterior, superior pancreatic duodenal artery. And where are they coming from?
Which one?
These.
What?
These arteries that you mentioned,
I
so
know,
right.
which one? He says.
Where are they coming from?
The superior.
They are coming from the gastroduodenal artery. Understand? And from the lower end now of the pancreatic head, we have the inferior, anterior, and posterior pancreatic duodenum, and they run up and down together, don't they? So nice and easy.
That's from
And that's just coming from the superior vesicle. And the arcade between the two, what they call this arcade?
Arc of Kirk or something. Arcade of Kirk. Yeah, arcade of Kirk. No.
Not that one? It's not that one? Okay.
He doesn't have a name.
My bad.
That's not me.
No, no,
They
no.
don't like to work.
No, the inferior one. The inferior one doesn't have a name, but the anterior one does.
Yeah, and that's the most between the superior and inferior is called it. When Mr. Gardner said he's the man that was invented, the rear branchial arcade.
It's given
It's called the rear branchial arcade. You understand?
Rio Bronco.
With the rear branchial arcade, yeah? Now, when you look at the body and tail of the pancreas, yeah? At the top of the upper part, there's an artery running up, you know, the splenic artery. And at the lower part of the pancreas, there's another artery running down there too. What's that called? At the inferior border of the pancreas. The inferior pancreatic artery. So the splenic is really the superior pancreatic artery, don't it? In a sense, no? And at the lower part is the inferior pancreatic artery. That dorsal pancreatic artery, when it comes down, it divides into two. A branch that's going to give rise to the inferior pancreatic artery, another branch which goes toward the head of the pancreas, right? And that partakes in that arcade you just mentioned, the arcade of Kirk. Right, it forms the pre-pancreatic arcade of Kirk. With me? So you have a superior branches from the splenic artery, which is in brackets, is the superior pancreatic artery, that's what?
Yeah.
And at the lower end, the inferior pancreatic artery. And they have branches which are anastomose with each other. And you should remember the name of these branches, don't you? The larger branch is the, right, Valhalla's pancreatic or arterial magnum, yeah? And at first they thought it was the largest, right?
So he was wrong.
Huh?
He was wrong.
Yes. Because subsequent research showed that the dorsal pancreatic artery was described by Kirk, by the way, is largest. No?
So that's wrong. Okay, so it's-
And as you go further toward the tail of the pancreas, you have the, huh? You have the caudal. pancreatic artery. Chorda is tail. So you understand how the segments come about? They follow and the branches, the supply how more orderly it is now. Yeah? So you need to understand that. So Mr. Gardner is supposed to talk about spleen tail. Ray Brown. There are many things that will talk to you, not in the book. So the spleen. Similarly, another organ. And so we let them to divide the spleen into segments. So pulmonary, hepatic, pancreatic, splenic segments. Are you with me? Even for the lunch one, you need strong man. Okay. What about the splenic segments in our book?
Segments, any spleen.
Yeah.
It's like impression.
Yeah.
Yeah, the impression, just like impression.
They have like how much I
It said that usually about 5 segments, you know? And they are supplied from branches. They said the splenic artery goes toward the spleen, is like a handshake, you know? Into 5 branches. And going to the upper and lower part of the spleen, you have the superior and inferior polar arteries. And the other 3 middle ones are called the superior, middle, and inferior terminal arteries. Those are the segments. Now from these segmental branches, arterial branches, yeah, going towards into the spleen now, yeah. What are the branches? Dr. Thomas, that's really from first to this. What are the arterial branches? So you see we turn to the segmental to the 5. So the segmental arch is going to go into the spleen now. What after that? I'm sure a lot of you, like me, would have watched the movies, and them always have this famous cathedral in Rome, which I managed to visit live. And I went over Europe. Hello. I'm having successful passing.
That's a hello.
Everyone know that. Yeah, man, they show this big cathedral in Rome, and what's the name of that cathedral? You see it on TV.
In Rome?
Yeah.
Is it in the Vatican or is it like in Rome?
St. Who's Cathedral.
Saint who?
St. Who.
Okay.
Is it like Jose?
When you get married, you know, you on your main street have to go to visit Venice. Just ruin the gondola at night time. While them singing love Italian songs to you.
You don't fill your head with expectations.
That's the life romantic,
Yes.
you know.
I can't live up to that. I can't live up to that.
You never heard? Yeah, somebody said it. St. Peter's Cathedral.
That's in Russia.
That's the name of the church.
Isn't that in Russia?
You never heard about St. Peter's Cathedral,
Yes,
that famous church? Right. So the S is the segmental. The T. The spleen doesn't have a good capsule or nothing, especially in children.
It's poor in children.
In children, the spleen capsule is very good.
Okay.
We adults, it's not good.
Okay.
So when the capsule is good, it sends anything into the spleen, the animal. Right, it sends fibrous tissue into it, man. It's called the trabeculae. So you see, we come out ST, and you guys know what ST means.
Bro, elevated ST segment.
That is funny, bro.
You don't know what the term ST up here means? No. And this is an advantage when you don't live on campus, you know? Because in the former days of university, every student, first year student, had to live on campus, whether you're medicine, whether you're law, economics, geography, whatever.
I live on campus and I don't know what you're talking about, sir. I don't know what you're talking about.
So, apart from talking love to your main schools, when the guys and girls meet together and talk,
That's why I don't know.
we have to chat a lot of foolishness. So the doctor can't go talk to a economics student about liver, or he talk about whatever equation for his
If they
economics.
love you, they listen.
Yeah, but it's not making sense. So we have to do
Good job.
a lot
No, I
of
want to
nonsense
just
talk, don't it?
Sure.
Yeah, we talk a lot of nonsense talk.
we.
And the famous word at university is that we have a
Aye.
ST session, you know. And you know what S is? Eh? Not sense talk, but how we can go argue sense with an economics student. ST from the bottom in, you know what S mean, no?
No.
Yes. Oh. ST.
You mean sacrum, bro? The ones from the
But you know
bottom.
what to-
Sacrum, bro. It's just sacrum.
The S is that thing, you know, that solid structure there. So we students would talk a lot of ST. A lot of ST. So you see, must be told to you.
We're too young.
No, you're not too young. From the kids here, you're supposed to know ST, you know. Yeah, when the economics student, medical student, geology student, law student, we together. We have to chat all about foolishness, don't it? ST. Okay, so you understand? Segmental, terminal, trabecular branch, right? And the other two now is what? St. Peter's Cathedral. What is the P for?
It's selling.
The pen.
Selling.
Pen.
Right, say it, say it, say it.
Pen.
What is the drug called?
Pen.
What is the drug that you're trying to tell me? Penicillin is the drug, right?
Penicillin.
Right, so you don't get penicillin here, you get penicillin arteries, huh? So St. Peter's, eh? So why they call it penicillin arteries? Hmm? Why they call it? So it must be a reason why. Because the arterial patterns look just like the penicillin mold as it grows. You understand me? Remember, Fleming was the guy that discovered penicillin. So that's the penicillin arteries, eh? And the C, from the penicillin arteries, you get the C arteries. Which is the, who again? Say? Who? Right, you get the central arteries. And what is the characteristic feature about these central arteries? Mr. Gardner showed you on this picture yesterday. The key thing in the spleen, they look like the tonsil. The key thing is that it has
Central artery.
right showing on it, the central arteries. No, say it. You're in here? Yes. And what is the key thing about this central arteries? They have a pals, man. You hear about pals at the Jamaican school pals? You heard about pals?
Yeah.
You heard about pals in school?
For the advancement of literacy, the thing.
Peace and love in school, man. You boys and girls are always killing each other. You never remember that face. Yeah.
Are we really good
You can lift off his mouth, man. Camera. Camera. They're surrounding very arterial lymphatic. And then you have the white and the red color. And what separates the white color and the red color? What separates the white color from the red color?
He didn't, we can just pull this in for me.
Sure.
Just.
The mantle zone. Mantle zone. Okay, Charles, you're on here.
Yeah, the game has never been this gone. I believe that he's got to do this.
He's an actor. He's an actor.
I'm going to read for you, it's not bro, so I'm sorry about this.
Which part are you doing?
I don't know what I'm doing. I don't even know if my group will come in, bro. I haven't studied the whole thing, bro. The group dropped from 42 and I don't know if the second one I fall, bro.
So let's take a look first at this specimen. Open up.
Second, you know.
Okay. No, what I want you to see. Come down here hard on this now. Hard.
Sorry, fast.
So we're in now down here in the sigmoid colon. Okay? And it's a disaster. It's a disaster. Okay? If you show it picked up to the light,
Fully give
you
up, bro.
see that there are all of these diverticuli. There are all of these walls. Whoa, look at that. Patrick, point to the diverticulum.
We're home to speak, it's not going to eat.
See? The point to it.
Just a little bit kind of
Look at that.
What you see is
Look at that.
all of this.
Oh my God.
You see that hole there?
I don't want to go with the lash.
What is this?
There. Further on. Further on. There.
See how thin this is now?
The mucosal function.
And you can see the relationship of the diverticulum to the structure.
Yeah.
What is the structure that's running there?
Tinea coli.
And that is where the blood vessels come in, right in the weakness.
So this is like the go. So there you can see now that this is a disaster. This is a very advanced case of diverticular disease. Right? This is a diverticular disease, and you can see all along there. There's just massive outpoaching.
Because
Dr. Lodenquai will tell you why in the sigmoid colon using a law of physics, that in the sigmoid colon you're going to find it just riddled with diverticuli. See there?
They should be.
Riddled with diverticuli. Okay, so this person had very, very bad diverticular disease. So sigmoid colon, and then we're coming up here, and we're coming back around, coming back. So that is the, right here, that's a long sigmoid colon here. Okay, then this is the ascending colon, we're coming up to here. See the ascending colon? Not so bad here as we see it. But when we get down to here, it's a total disaster. So these tiny little mucosal outpoachings in the diverticulitis, when there's an inflammation, many times now it will break down. Okay, fecal material will end up in the peritoneal cavity. Person will bleeding. Remember, these are the vasa longa and the brevia, right? After they pierce it, and where they pierce it, it forms an area of neural weakness. And when that area now becomes problematic, then no, when that area becomes problematic, see, that's just mucosa there, you know, mucosa. Thin. This one here is so thin, it isn't funny. Look at that one. See there? How thin that is. You see there, Patrick, look at that one. Right? That couldn't be more thin, right? So fecalites, when fecalites get in there, and then no infection and that sort of stuff, then they will just rupture. So a person like this may have to get no a colectomy. They will have to do that. In fact, to a person like this when he gets bad, bleeding in the stool, terrible pain, and sometimes fusing with like things like urinary bladder and fecal material passing there, right? And then when we come around here, we're now at the right conic flexion, and you see when we come down here, we're now right here in the cecum. Okay, and then when we look in the cecum here, we pick up the beautiful. So there you will be able to see now the what. What am I looking for? The ileocecal valve. Okay? The ileocecal valve. Just give a try. The ileocecal valve. Okay? Around there we should find that valve. Okay? Not so prominent in this person here. Okay? Iliocecal valve. Most prominent in our nervous system. Okay, so that's just to show you what that diverticular disease. Okay? So, remember, 80% of people in the UK have diverticular disease.
That's insane.
80.
They saw them beans,
They
saw them beans on
It's
toast.
the zero.
Oh, them fish and chips, bro.
So we're looking here at the specimen, and there we can see the zoom it all up here, let it fill up the whole screen, or come back up. So there we can see the spleen, right? That's the gastric surface of the spleen. That's the hilum of the spleen. And we see now that there are a number of vessels. Okay? This big boy here, you will see two big boys. This boy here is the one. So I see two boys. Okay? I see now two boys. So Brittany, which two boys do you think these are here? Who is this boy right here? Yeah. The vein. Right. The vein is more straight. Right? Okay, it runs on the posterior aspect. And you can see the wall is thin. This wall is thick. And it is in a serpentine fashion. Okay? Alright, so that's the splenic vein. And that splenic vein will be joined by what? Splenic vein is, you see how massive the splenic vein is? Look how big that vein is. So that splenic vein is going to be joined by the inferior mesenteric.
It's German both, and then there's a
So we come around here, and you see the shape of the pancreas, prismoid, right? And along, that's the superior border here, because that's it. There we can see the splenic artery. So therefore, attached all along here will be what? What attaches all along here? See how long the spleen is? The pancreas is going right across. See the pancreas coming right across? And who is attached all along right here? Transverse mesocolon. Right? Transverse mesocolon. And then it's going to go across the what? The head of the pancreas. Okay? And the head of the pancreas lies where? In the C shape of the duodenum. Right? We'll come back like that. And you can see now that's the superior duodenal flexure. And if you feel here, this is very thick and bulbous. Right? So that's the pyloric sphincter. See the pyloric sphincter right here, right at the transpyloric plane. And you'll see the direction of the superior, of the first part of the duodenum. What's the direction of this, of it? What's the direction of the first part of the duodenum? Upwards, backwards, and to the right. Upwards, backwards, and to the right. What's the direction of the gallbladder, the long axis of the gallbladder? What's the direction of the long axis of the gallbladder? Backwards, upwards, and medially. Boom. B-U-M. Backwards, upwards, and medially.
I don't even care.
This is upwards, and to the right. Is that so?
Sure.
Then, so that's the superior duodenal flexion. There is the C shape of the duodenum. And there we see the inferior duodenal flexion. And there we see the what? The head of the pancreas. Okay? Now there we can find now just posterior to the pylorus. See the pylorus here? Just posterior to the pylorus. This is the constricted portion here is called the neck. So it's constricted, I can just feel it. See when I go like that, I just feel the neck. And then we're traveling right through here would be what? That's sometimes called the tunnel of love. Leave it all. So
Leave it
all
all.
through here would be where we will find what? The hepatic portal vein. So right in there, right in here will fit what? The one is fitting where my finger is right here. That's the superior mesenteric vein. Right? That's the superior mesenteric vein and the artery. the superior mesenteric vessels. Okay? So that's the neck of the pancreas right here. So the HPV is formed right behind here, and then that big boy that's coming across, that's the, see the boy coming across here? That is the splenic vein. The splenic vein is going to be formed, joining in the body. Now in this case here, when you look along the splenic vein, look at that, Patrick, this inferior mesenteric vein is joining very close to the superior. See, it's not joining it all the way along here. See there? There's nothing coming from below joining it. So it doesn't join, it doesn't always have to join it way down here, you know. It's variable where it may join it, okay? Alright, but it's usually very important is in relation to the DJ flexion. Right? So when they're paraduodenal fossa hernia and they're repairing anything along there, they have to be very careful of the inferior mesenteric vein. So that's the head of the pancreas. And then that head of the pancreas now, what's been dissected off is what has been dissected off right here. So there will be a structure. So the superior mesenteric vessels are here. And okay, so it's here. In fact, it's part of it is here. What is that structure here? What is all of this here called? The uncinate process. Right? So the uncinate process is right here. That's the uncinate process. The uncinate process is this prolongation. See there? See like that? It's a prolongation that's what? Posterior to the what? To this superior mesenteric vessels. Okay? So it's going to separate now the vessels, and then now, if that's the superior mesenteric vessels right here, then you see now that coming right here, so that the uncinate process is going to be, in a way, kind of protecting from what? The third part of the duodenum. So the third part of the duodenum is right there. See the third part of the duodenum, and coming right over will be the mesenteric vessels. So it's like it's resting its head on a pillow. Right? And then now, Dr. Deng will tell you, Wilkie's syndrome, just going back quickly over and then get the point. Wilkie's syndrome now, there's compression, right, and there's pain, and then when you turn the patient over and place the patient in the prone position, sometimes the pain will disappear. So when they're trying to do a differential diagnosis, or they do radiological studies, you just take the patient and turn the patient over, right? So there you can see now that's the third part of the duodenum, and that is the uncinate process, and that tunnel right here is very interesting, very, very important. So when we look now at another specimen, because when we make a little, okay, when I look at this specimen here, so you see, by the way, that's the stomach. So let's look back at it. See the stomach right here? So this person had a good appetite. Good appetite, right? Okay, but you can, wow, look right down there. Look what you're looking at right there, Brittany. Look down, man, look right there. What do you see? No, man, come and look here. Come right here, sweetheart. Here. And look down in there. What you notice? This is esophagus here, and what we see this. You don't see it. The constriction. See the constriction here? Let's go on look. Quick sound. There you see. So that's the constriction. That's at 40 centimeters from the upper incisors. So the first constriction, we know where it is. So this is the last one. It's at 40. You can see. Look at the diameter of the esophagus here. And look what you see here. So that's a constriction. Look how tiny that is. Considerable constriction. Yes, sir. You see it? Yeah, take a picture. Why not see it again?
I don't chew my food, bro.
To the exam.
Of course you don't.
Right, so that's 40 centimeters. Right? That's beautiful, isn't that right? Right. And then now here we're coming and we see the fundus of the stomach
That
right here.
actually is a thread.
And we're along the lesser curvature. And we see the muscles. Boys, the left gastric artery. See the left gastric artery right here. Coming up right there. Look how big the left gastric artery is and the left gastric vein. See how big the ball is right here? See the ball is quite big? Okay, those are that. Okay, so when we look here now, we will see now the pancreas here. Right? So we come and then put the phone back in the correct position. Okay. Just relax. So there is a stomach like that. See how everything goes? This is how it goes. Alright? So that's the stomach right here. There's the pylorus again, and it's cut. So the first part of the duodenum is cut right a little proximal to the what? To the superior duodenal flexion. There is the what? The second part of the duodenum. And we open it up right here. And we're looking and we're seeing. Right. Okay, take the red probe. Touch the.
What are those?
Yeah, this way.
Good God.
Okay, touch the what? Major duodenal papilla. Minus. And then what do we notice about the first part of the duodenum up here? We don't see much PK at all.
Yeah.
But then we start to see them here. See them? They're coming along. Major duodenal papillas right there. So the head of the pancreas is going to. No.
Oh.
So the head of the pancreas that we see here now, that's the head of the pancreas. And look here, it's overlying. See how it's overlying the duodenum? So though it's described as being in the concavity, you see that this is growing over. So normal healthy spleen, nothing wrong with it. Okay? And you can see now that there are vessels coming off here. So there will be a superior, there's a pancreatic arterial vascular arcade. Okay? Now because the duodenum and all that, we're going to have the midgut is going to meet the foregut and the major duodenal papilla. So common sense is going to tell us that this is the domain of the celiac artery and this is the domain of the superior mesenteric artery. So the gastroduodenal artery is giving rise to anterior and posterior, superior pancreaticoduodenal, and the inferior pancreaticoduodenal artery. That's all this is implying the head, you know. And that's from the what? From the superior mesenteric. So the very early branch coming off from the superior mesenteric will be the anterior and posterior superior pancreaticoduodenal arteries. So the duodenum differs. This area of the duodenum differs to all the rest of the small intestine in that we get two sets of blood vessels. Right? And if we look here, see them, there are a number of them here. Right? See them right there, so we can blow it up big.
Yeah.
And these vessels are referred to as what? Who are these boys called? And if you ask Britannians, you say these are the vasa. These are the vasa. And the anastomosis in between coming from the superior pancreaticoduodenal, right, and the inferior pancreaticoduodenal. Okay, so we're connecting it up now. Celiac trunk with what? Okay, and more so gastroduodenal with the superior pancreaticoduodenal. That's referred to as the anastomosis of which anastomosis?
No.
Not at all. Real broncho anastomosis. Not broncho, you know. It's horse. It's not real mirror, real broncho. Real broncho, actually. Here the name,
No one has found this.
Broncho. It doesn't end with an A or O. Check for me now. No man is there. No man is in the Google images. A or O. Bronco. Just check it for me. So I give real bronco. We want to check. I don't want to tell you no rubbish. Okay? So there you can see the head of the and you see, which one is it? O or the A? O, bronco.
It's different. It's different. Arc of
Real
Real is
bronco
left and middle.
anastomosis. I want you to remember that. Real bronco anastomosis. Okay?
Oh, you want?
So there you can see the head, and then now when we come across here, look at this here now, this is beautiful. So there you can see the head, and then now the transverse mesocolon is going to be attached a lot across the head of the pancreas. Yeah, you know, it's going to be attached.
Yeah, mash it up, man. Mash it up, Dominic.
So it's going right across here.
transverse interforamen.
Yeah, the transverse interforamen is just coming right across the head.
Right.
And then going right along the inferior border, the sharp inferior border here. So it's therefore going to put the pancreas in the supracolic compartment and the infracolic compartment. And therefore this part here of the body here, and the neck, yeah, the neck, yes, but the body, and it's going to be the top part of the what? The stomach bed. Very important. Look at this boy and look how he's highly tortuous.
Yes, sir.
Look at that. No, you're not forgetting it, Alio. Yeah, yes, we have. Just follow me hard. Right? And you see this artery is like undulating. It's undulating, like a snake. It's undulating, undulating, undulating. Look at that. And the vein is totally different. The vein here, straight. This is running on the superior border. This is running on the posterior aspect. And this boy here, that splenic artery there, is going to give rise to, Dr. Ledlin was saying, one of the largest branches, and that's the dorsal pancreatic artery.
Okay.
And that dorsal pancreatic artery is going to descend and form another transverse branch going right across. Yes, so going right across. No, that's the dorsal pancreatic artery. So it descends, and there's a kind of a longitudinal running, transverse running vessel.
Transverse. Inferior tips.
Inferior.
Transverse inferior pancreatic artery.
Transverse inferior pancreatic artery. Transverse inferior pancreatic artery of Von Hallo. Okay?
Oh my gosh.
So there, but it's a dorsal pancreatic artery of Von Hallo.
Van
See?
Halen owns something like
What is your name, Alio?
What you
You
say?
need to meet Von Hallo.
The man them old man money or something, bro. Bro, if I go in the spot and I forget something, bro. If I go in the spot and I forget something, I say that man name, bro. Is the class online or in person?
I'm not going to stop the course.
Is that the course? Why?
Because she told me I shouldn't leave.
Why?
I was going to stop her. I told her that I shouldn't leave. I should say,
Wouldn't be fair, how?
I shouldn't leave. I should email them.
It shouldn't be, it's not fair to go. Wait, as in, you've completed your foundation courses?
Yeah.
Okay, fine.
So it's a dorsal pancreatic artery of curve. Curve. Yes, of course. So there are numerous pancreatic branches that are coming off.
Wait, it's the same place though?
What is also very important is the arterial pancreas, the magnum.
Adrian is
So
doing.
you can see that's the body of the pancreas. So
Oh, Adrian in there? He's in our class? He's in our class?
Covered by what? Peritoneum. Okay, and see all of you are still here. So then you will see now that tail. Tail, that's the tail of the pancreas. And that tail will come right up. It's tail, and you can see there's a kind of a difference to it right here. That lies in the linorenal ligament.
The what?
In the linorenal ligament, we're going to get the splenic arteries, this big boy here, and Dr. Ledlin was dividing into segmental branches, the splenic vein, and there's some lymph nodes. And those are the pancreatical splenic nodes. Always asked in the exam. Pancreatical splenic. Okay? Now, you just spend 1 minute here, and you will see here that's the spleen. Okay? Don't relax yourself. So that's the spleen. Here. See how it is? Like that. So it fits in.
On the
Show me, Britain Alio. There. Oh, where is it though? The spleen. Swing it around. See where the spleen is? Right there.
Right.
See where the spleen is? It's like this.
Okay.
Right? So it anteriorly it extends to the mid-axillary line and posteriorly, what's going behind me? Posteriorly goes to the scapular line. So anteriorly it's to the mid-axillary line, posteriorly it is to the scapular line. 1, 3, 5, 7, 9, 11. 1, 3, 5, 7, 9, 11. Odd numbers. 1 6, 3 inches wide, 5 inches long. In the exam, always ask when you get a splenomegaly, how much does it have to enlarge by before you can feel it? 2 to 3 times. 2 to 3 times. 1, 3, 5, 7, almost the same weight. 9 to 11. It's covered by it extends from the 9th rib to the 11th rib. Okay, so that's the 9 and 11. And it follows the direction of the 10th rib. So it expands towards the umbilical. And it is said that you can feel the splenic notch. Okay, so when there is a splenomegaly and you examine the little baby's tummy, Bustamante, that you can feel the splenic notch. Or else you're going to see a lot of splenomegaly there. Okay? Okay, relax. That's the hilum. That's the gastric surface. Splenic flexure, so the left colic flexure is there. Okay? And supporting the spleen, right here is the phrenico-colic ligament. What ligament? Phrenico-colic ligament. And this here is the luminal surface. The spleen is very friable. Okay? So accidentally, as I was putting it back up last time, it fell very well. Didn't fall a long distance, just fell from here. And you can see it fall. Here.
I didn't want to
Very
stop
small follicle, very friable the capsule. In the children, Dr. Lodenquai was saying thick. Yeah, and then Dr. Lodenquai would talk a whole 2 hours on why do people at Bustamante Hospital try to preserve the spleen. So it's all with their immune system, right? So the immunological function of the spleen is phenomenal. You try, okay? So you try to avoid a splenectomy. So maybe you try to take off that part of the spleen maybe that's damaged or so. Okay? In an adult now, that there's a trauma or an accident and it's torn, then it was splenectomy. Okay? So you see that's the splenic notch. So you can see that the gastric surface is past the examine now. What is related to all these areas? So Crystal, what you have to know, sweetheart, is that and for these folks, Mr. Sam, Dr. Sam, they'll always give you this in the surgery exam. You hold it like this, and your finger goes into the splenic notch. It's like that. Talk to me about spleen. If you remember the ligaments are the linearenal ligament and the linearenal and the gastrosplenic. And here you see the surface. And then now, this is in a person here now who was in a we call it now, what crisis again, probably? Sickle cell So this person actually was, I knew this individual, a young guy, maybe in his 20s, he died following a severe sickle cell crisis. Again, you go into the body anatomy. And there you can also see the splenic notch. See the splenic notch? That's the gastric surface, and that's the renal surface. Okay? So students back there, you were 20. See, there are a lot of students still left back. Alright, so I hope you all guys enjoy your lunch.
Thank you.
Well, stay, that's a good thing.
Well, see y'all for enjoying it.
This is the
It's all alone.
But students, I'm sure this is
Just leave it all alone.
daughters in 1 minute. So you see this diverticular disease. I tell you, about 80% of these